Welcome to EADV Live. Today's topic, cutaneous T-cell lymphoma with Professor Emmanuela Guenova. I'm Christopher Horskamp, and on behalf of the EADV, welcome to today's webcast. Before we begin, we'd like to let you know that our presenter will be taking questions and comments at the end. If you're watching this through Facebook Live or YouTube, or for our EADV members through Zoom, you can post your questions in the comments section or chat section at any time throughout the presentation, and our presenters will do the best to address them at the end. Today, we're joined by our presenter, Professor Emmanuela Guenova. She's a consultant dermatologist and professor at the Faculty of Biology and Medicine of the University of Lausanne in Switzerland. Her specialties and interests are focused primarily on skin immunology and cutaneous lymphomas. Professor Guenova, thank you for joining us today.
Thank you very much, Christopher, for the kind introduction. It is a true pleasure for me to be live with you today with this webinar focused on cutaneous T-cell lymphoma. If we already have the presentation on screen, I will be happy to guide you through the learning objectives of today's session. I will try to help you recognize the most common entities in the large group of cutaneous T-cell lymphoma, to help you understand the current concepts in the treatment of early and advanced disease, and to gain knowledge about newly developed treatment modalities. First, we will spend a few minutes on diagnostics and staging of cutaneous T-cell lymphoma. In general, the group of primary cutaneous lymphoma is a large group encompassing more than 20 different subtypes of lymphoid neoplasias, which have in common the initial presentation in the skin without any extracutaneous involvement at the time of diagnosis. Those are rare diseases, and within the whole group, the primary cutaneous T-cell lymphoma are the major subgroup with around 75 to 80% of all cutaneous lymphoma. Out of those, most importantly, the most common one are Mycosis fungoides and Sézary syndrome, followed by the primary cutaneous CD30 positive lymphoproliferative diseases. Looking at the percentages, it is very quickly clear that approximately more than half of all patients in the group of cutaneous lymphoma in general are patients with either Mycosis fungoides or Sézary syndrome. So that's why I will concentrate predominantly on those two diseases today. Mycosis fungoides is by far the most common cutaneous T-cell lymphoma. It is a slowly progressing disease going through patches, plaques, and tumors throughout its evolution, although it is also possible that patients are initially diagnosed directly in advanced tumor stage or erythrodermic stage. For the staging of Mycosis fungoides, it is essential that you are aware of the TNNB classification, which in contrast to all solid tumors, includes not only the tumor nodule and solid organ metastasis part, but also the blood diagnosing, the B in the cutaneous lymphoma diagnosis. Based on this, we can stratify all patients with Mycosis fungoides or Sézary syndrome from very early stage 1A disease until stage 4B disease, which has organ involvement very seldom and may have pronounced blood involvement. And this is important for the prognosis, which gradually worsens with the advancement of the clinical stage. Important, stage 1A to 2A disease are regarded as early stage disease with far better prognosis over time than stage 4 to B disease and up, which we call advanced stage disease. It is important to know that of all patients, most patients are in the early stage disease, stage 1A, 1B at the time of diagnosis. And out of those very early stage patients, only very, very few will advance and worsen their stage and develop more severe disease. Also important when communicating to our new patients is that stage 1A disease has actually a median survival which does not differ to age-matched healthy individuals. And here it comes the challenge. We have a rather common cutaneous T-cell lymphoma relative to the whole southern group of lymphomas. Then we have 70 to 80% of all patients that present in the early stage of the disease, which is very difficult to diagnose. Main differential diagnosis being inflammatory skin conditions. Most of those patients are misdiagnosed or not diagnosed. They have a very long doctor journey behind them with 4 to 6 years on average from initial skin symptoms to the final diagnosis. So here the main challenge is the early and accurate diagnosis. And in line with this, I would like to remind you of the current basic diagnostic concept for mycosis fungoides and the existing diagnostic criteria. So mycosis fungoides is primarily in the early stages a skin-limited disease. That means we strongly rely on clinical appearance, which will give you 2 points for classical clinical appearance, like patches or plaques in non-exposed location with typical shape and size, maybe porculoderma, and persistent and even progressive. And the second pillar, next to clinical appearance, will be the classical histology, hematoxylin eosin, which usually shows superficial lymphoid infiltrate, epidermotropism, with or without spongiosis, so be careful, spongiosis does not exclude lymphoma, and some lymphoid atypia. And having those 2 points for clinical and for typical histological appearance already makes the 4 points that we need for diagnosing mycosis fungoides. Additionally, the further pillars of the diagnosis rely on molecular biology, and here, currently, the only one recommended is the clonal T-cell receptor gene rearrangement with the standard Biomet2 PCR-based method and immunohistochemistry with detection of predominance of CD4 cells versus CD8 cells and some immunophenotypical changes, most common of which the loss of CD7 and CD2. So those criteria have been proposed by Pimpinelli in 2005, and they have been revised in 2015 to confirm their sensitivity of around 87% and specificity of 60%. So this is what we have so far as established the diagnostic criteria for mycosis fungoides. Once the diagnosis is clinically suspected and verified on clinical pathological correlation, it is a natural question what staging evaluations are necessary and recommended. And here we rely mostly on the written German guidelines and ESMO, European Society of Medical Oncology guidelines that recommend complete clinical examination, especially the clinical SWOTs and CALES and scores for staging of the skin disease, palpation of the lymph nodes, skin biopsy, if one is not enough and not representative, sometimes multiple biopsies with clonality assessment with the Biomet2 protocols is required. Imaging with CT scan and PET-CT is optional for patients with early stage disease and recommended for patients with advanced stage disease. For the laboratory studies, and this is very important regarding the diagnosis of Sézary syndrome, recommended is complete differential blood count and LDH, as LDH is one of the prognostic markers for the disease. And for assessment of the tumor burden, flow cytometry or obsolete the blood smear to detect Sézary cells. In flow cytometry, those will be defined by CD7 negativity or CD26 negativity on CD4 cells and additionally elevated CD4-CD8 ratio. Also for the blood clonality assessment is needed. Everything else, like lymph node biopsy or bone marrow biopsy, is not necessarily required unless indicated by other staging assessments. The blood diagnostic, as I mentioned, is important for the diagnosing of the Sézary syndrome. And I would like to show you the currently existing criteria for Sézary syndrome diagnosis, which is, of course, suspected clinically by the classical triad of erythroderma, lymph node involvement, itching, and blood involvement. But for the blood involvement, we need flow cytometrical diagnosis. And here are the criteria. We need one of the following, according to the International Society for Cutaneous Lymphoma: elevated Sézary count, increased lymphocyte count, plus immunophenotypic abnormalities such as pathologic CD4-CD8 ratio above 10, and aberrant loss or gained expression, most commonly loss of CD7, CD26, and a demonstration of the clonality of the blood, or slight modification according to the WHO EORTC classification. And as the current proposal recently suggested, moving away from morphological detection of Sézary cell and more precise categorizing of the blood involvement in B0, B1, and B2 stage, depending on the precise number of tumor lymphocytes that can be detected on flow cytometry. Why is this important? This is important because I would like to stress again that cutaneous lymphoma are defined as diseases of the skin without blood involvement at the time of initial diagnosis, but for the Sézary syndrome, which requires blood involvement and is actually diagnosed by its blood involvement at the very initial presentation of the disease. So mycosis fungoides and Sézary syndrome use the same TNMB classification and staging system. However, the first stages from 1A to 3A are possible for mycosis fungoides, but are not possible for Sézary syndrome, which has to be with detection of either erythroderma, so total body redness, above 80% of the body surface area, or blood involvement at the level of B1 or B2 disease. So this is a classical example of a Sézary syndrome patient with pronounced erythroderma, 46-year-old female patient with rash and itch since more than 6 years, and as most of the lymphoma patients, with a long doctor's journey behind her and not yet clear diagnosis until she presents with weight loss of 6 kilograms in the last 12 months and this pruritic erythroderma. The prepared mind will quickly look for either atypical aberrant lymphocytes in the blood smear, or will detect elevated leukocytes in the blood, and aberrant loss of CD26, CD7 above 30 or 40%. Strongly elevated CD4-CD8 ratio, 47%. The range is 1 to 5. And even if you go further, you can even detect on flow cytometry the aberrant V-beta-2 positive clonal population, which makes the diagnosis of Sézary syndrome very, very clear. However, it is important that not every Sézary syndrome is presenting so classically. In an international, rather large retrospective analysis of patients diagnosed with Sézary syndrome and their clinical manifestation at the initial time point of the symptoms, of the skin symptoms, it looks as if actually no more than approximately 1/4 of all patients will present with a typical erythroderma, here 25%. Almost half of the patients have a non-specific dermatitis, and some of them may even mimic atopic dermatitis, may mimic mycosis fungoides, or can even have a leukemic involvement without initial erythroderma, at least in transient cases. Prognostic factors for mycosis fungoides or Sézary syndrome are currently being still vigorously analyzed. What we know so far is that stage 4 disease, that means erythroderma and blood involvement, age above 60, large cell transformation in Mycosis fungoides, or LDH in both diseases, as well as T-cell receptor frequency above 25% for stage 1B disease and above, detected by high-throughput sequencing methods, are significant bad prognostic factors from the one that have been analyzed so far. Here is a very nice example from a patient-dedicated leaflet of the typical clinical features of Mycosis fungoides and Sézary syndrome. You see the Mycosis fungoides lesions going through thin patches, a little bit thicker plaques, and tumor lesions, which will be advanced disease. And the signature beside the erythroderma for the Sézary syndrome, don't forget those patients may have a very pronounced ectropium and palmar plantar keratoderma. How do we treat cutaneous lymphoma? Or better said, today we will discuss how do we treat early and advanced stage Mycosis fungoides and Sézary syndrome. Treatment is based on patient's disease stage. So usually early stage disease, stage 1A to 2A disease, so skin-limited disease with patches and plaques. First-line treatment is recommended either expectant policy, watchful waiting, the prognosis is favorable in this stage of the disease, or skin-directed therapies. And here you see the level of evidence from level 4, the lowest, towards level 2. So level 1 we do not have yet for the lack of big prospective randomized clinical trials on skin-directed therapies. What is recommended is, and most commonly used, topical corticosteroids in combination with phototherapy, PUVA as the original recommendation, and now because of proven lack of inferiority for UVB, also UVB treatment, or localized radiotherapy in some exceptional cases, and what is now new available in Europe, mechloretamine under the form of chlormethine gel. If this first-line treatment is not successful, we have the second-line treatment for early-stage disease, which goes over the skin-directed therapies to systemic therapies, and very, very common combination of all those different treatment modalities. So here, classically, we rely on low-dose methotrexate, 15 to 25 milligram per week, with a very low level of evidence, though total skin electron beam in exceptional cases as a palliative radiotherapy, and very, very common with a good level of evidence, interferon alpha and retinoids. In a very large, prospectively collected patients' data set, it was analyzed the physician treatment's choice in 395 newly diagnosed patients with early stage MF 1A, 2A. And interestingly, the first-line treatment chosen by physician, by you basically, was skin-directed therapies as a first line in 80% of all patients. And out of those 80% on skin-directed therapies, the overall response rate was actually 73%, as documented in this large prospectively collected patients' data set. And for systemic therapy as a first-line treatment, the overall response rate was significantly lower, with 57%. Of course, those numbers change with the resistance to treatment of the disease and the advancement towards the second, third, fourth, and fifth line therapy for early stage MF, where things usually become a little bit more complicated. So how can we treat late stage? This is a little bit more complicated. There are large number of different guidelines and position papers, international, European, or from the US colleagues. And basically, we have a bunch of treatment modalities, systemic therapies, for patients with stage 2B tumors, to 4A and further. And we have to say that the only therapy that can promise curative outcome for the disease is the allogeneic stem cell transplantation. Before that, we have a bunch of established or newer therapies which are used alone or in combination, also in combination with the skin-directed therapies, especially as maintenance therapies, as long as the patients are responding to one of those therapies. So thinking about how to present this to you, I decided to show you what has been actually licensed for treating CTCL, because some of the treatments that we use are not really targeted for T-cell lymphoma. So maybe it will be interesting for you to know what is really within the indication cutaneous T-cell lymphoma. So the first one that has been licensed is actually the photopheresis in 1988 in Europe and the United States. And then what we have in Europe is Bexarotene, then Brentixumab and Mogamulizumab and the Chlormethine gel as novel treatment modalities specifically developed for the treatment of cutaneous lymphoma. So I will briefly guide you through all those different treatment approaches. The extracorporeal photopheresis is actually the first immunomodulatory therapy that has been developed for the treatment of CTCL, and later on found also application for other indications. So this is basically a combination of leukapheresis and photochemotherapy, which mimics the action of pure phototherapy on the skin, but is applied to the blood. Main indication here is, of course, leukemic CTCL, so MF, advanced disease, or Sézary syndrome. Another therapy that has been specifically developed for the treatment of CTCL is Bexarotene. This is a selective retinoid X receptor, so it's a slightly modified retinoid, different from the one that we usually use for the treatment of other dermatoses. And it has approved in 1999 by the FDA and EMEA. Since then, we use it a lot for the treatment of CTCL alone or in combination for early and advanced disease without exact knowledge of its mechanism of action. What you have to know about Bexarotene is that the dosage, the target dosage of 300 milligram per square meter per day necessitates at least a couple of capsules of Bexarotene, and then the patients, because of the obligate hypertriglyceridemia and hypothyroidism, have to have additional therapy with either lipid modifiers, fenofibrate, or thyroid substitution. So it quickly ends in quite a lot of pills that the patient necessitates to take per day. However, the results are encouraging, and especially for treatment-resistant early-stage disease, this is definitely a good option to consider. As the next treatment, I would like to present you Brentixumab vedotin, which is the first treatment developed and licensed for cutaneous T-cell lymphoma that has undergone the rigorous approach of a randomized controlled international clinical trials, which was some years ago very unusual for the field of cutaneous T-cell lymphoma. So what is Brentixumab vedotin? It comes actually from the the treatment of other CD30-positive hematological malignancies, but is also very welcome in the dermatology and cutaneous lymphoma field. It is an anti-CD30 monoclonal antibody, which is linked to monomethyl auristatin, which is a microtubule disrupting agent. And once it goes into CD30-positive cells, preferentially, this antibody-drug conjugate is disrupted, and the monomethyl auristatin blocks the formation of microtubulae and initiates apoptosis predominantly of malignant cells. So what you have to know when you are consulting your patients and you are guiding them towards this therapy, there is a certain percentage of peripheral neuropathy, which can be in a very small percentage of all patients, can persist even after the withdrawal of the therapy. However, we have meanwhile developed strategies how to cope with this side effect of Brentixumab vedotin. One option is to reduce the duration, to reduce the treatment frequency. So instead of every 3 weeks, every 4 weeks, or to reduce the doses from 1.8 to 1.2 milligram per square meter body surface area. So the next question that naturally comes is which subtypes of primary cutaneous T-cell lymphoma express CD30. It is very interesting. Also, very recently in 2001, a little bit larger patient cohort. Before that, single case reports and very small case series. CD30 can be detected on many different cutaneous T-cell lymphoma with good, but also with very bad prognosis. So it is definitely worth checking on immunocytochemistry for the expression of this marker, because in this case, we have one additional option for a treatment that might have not been considered, especially in the very seldom entities. Of course, the development of this treatment primarily has focused on the Mycosis fungoides, and especially the Mycosis fungoides subtype with large cell transformation, which very often co-express CD30. And for the exceptional cases of the otherwise with good prognosis, primary cutaneous anaplastic large cell lymphoma, for those cases that are a little bit more advanced and necessitate systemic therapy. So it is always nice to present one of the first large prospective trial with a very positive outcome. You see that most of the bars are pointing downwards, so we have a reduction of this MSWAT, the clinical score that we usually use to record response to treatment and to quantify the amount of skin disease burden. So you see that in MF skin, we have a much better response, and in anaplastic large cell lymphoma, even better skin response as compared to other standard treatments for skin lymphoma like methotrexate or Bexarotene. Recently, part of these data from the big trial on Brentixumab have been also reanalyzed to point out that there is no difference or no negative influence on the quality of life, especially regarding polyneuropathy, which is a very important message. What else do we have for the treatment of cutaneous lymphoma? Newly approved and already, especially also due to our experience in the clinical trials, widely used and very welcome. This is the humanized anti-CCR4 antibody Mogamulizumab. CCR4 is a chemokine receptor that is expressed predominantly in skin homing T cells. It is expressed also throughout all stages of cutaneous T-cell lymphoma. And this antibody is modified in a special way, the diffusilating part of the antibody molecule, which enhances the antibody-dependent cellular cytotoxicity, which is the main mode of action. It has also been investigated in another large-scale prospective clinical trial versus comparator apurinustat, which is an HDAC inhibitor not licensed in Europe. What we have to know about Mogamulizumab, it's very important. One of the side effects could be skin rash. The other one, infections, is a more common one, but the skin rash is important because it can hamper our assessment to the response to treatment, as it is very difficult to differentiate between skin rash and erythroderma, exactly in the patients that best profit from this treatment, patients with erythrodermic, leukemic, cutaneous T-cell lymphoma, and especially Sézary syndrome. So we see here that this is also the first drug that offers us a progression-free survival for cutaneous T-cell lymphoma as compared to the HDAC inhibitor vorinostat. And most importantly, when we look at the progression-free survival stratified by those B classes, that's why I stressed so much on the B class differentiation in the TN and B classification of cutaneous lymphoma. Patients with B1 or B2, that means detectable tumor burden in the blood, have a much better response, according to this data, than patients with D1, or that means patients that do not have tumor burden in the blood, to Mogamulizumab. To make the story complete, I would like also to present to you something that is very, very new for us in Europe, or well forgotten old. So for those of you that know the topical applications of nitrogen mustard back then, now we have a pharmacy-ready formulation of chlormethine gel, which is newly formulated, newly developed, and much more stable than everything else that we had before. And it is licensed in Europe and in the United States as a topical agent for all MF stages, and it can be applied to large surface areas. So what we have to know about this drug is that it can have, as a topical chemotherapy, some irritative or allergic skin reactions at the site of the application. So first, just as in Mogamulizumab, response to treatment may be difficult. And second, it may necessitate a combination of topical steroids for effective treatment. Last but not least, what are the products under investigation? The field is moving fast forward, and now we have a bunch of important and highly promising molecules that are in clinical development in stage 1 or 2 clinical trials, or even 3. So just to mention some of them, the anti-KIR3DL2 antibody or the anti-CD47 antibody, then miRNA 155 is also, not all of them are for T-cell lymphoma, some are also for B-cell lymphoma treatment. Then we are also analyzing the effect of immune checkpoint inhibitors like PD-1 or PD-L1, both in the fields of cutaneous B and cutaneous T-cell lymphoma, and also topical immunomodulators like toll-like receptor 7 or 8 antagonist, and many, many more to come. To summarize, cutaneous lymphoma is a large group of diseases. The most common ones are mycosis fungoides and Sézary syndrome. Especially mycosis fungoides is a disease that has many different stages and may have a very good prognosis. Progression may be slow, so treatment is stage dependent. The goal is to choose either expectant policy or tailored, skin-directed or systemic therapy to meet the goal. So what is the goal? The goal is ideally to reduce progression of disease, to slow it down, to reduce the tumor burden, and especially to improve the quality of the life of our patients. With that, I would like to thank you very much for being with me in this webinar. It was my pleasure spending 30 minutes with you talking on cutaneous T-cell lymphoma, and I'm very happy to take questions if you have any.
Hello, Emmanuela, and hello, everybody. It was a wonderful talk.
Thank you very much, Mirto.
Very thorough. I enjoyed it a lot. I wanted to ask you, maybe while waiting from people sending questions from the audience, I was always curious because lymphoma is something visible, and it's something that other people can see. Is there a lot of stigma or these kind of feelings associated with the lymphoma patients? Do you know if it has a psychosocial impact? So the visible disease, have you any idea about that?
Yeah, this is a very important question. Thank you for addressing. As always, when we are in the rush to deal with the clinical facts, diagnosing and therapy, we forget about the well-being of the patients. And indeed, these patients are young or middle-aged, so the mean age is around 50, 60. Men are a little bit slightly more commonly affected than women, but however, both sexes report that they have problems in their everyday life. Just because, as every skin disease, it can be stigmatizing. Usually, lymphoma will affect the non-sun exposed areas, but there are also very often plaques, especially in the facial area or visible area. So patients report that they feel hampered in their everyday clinical, everyday social life and private life. And this is one of the research areas that is now ongoing, because we do not have a specific questionnaire to assess this interesting combination of skin disease, inflammatory-like skin disease, but a tumoral one. So we have both components here. Trauma from the tumor diagnosis, but also visual impairment as from inflammatory skin disease. So this is very important.
Thank you. And I think members have started to ask questions. So there's one asking, is there a difference in the CTCL erythroderma versus erythroderma due to other inflammatory disorders? If you have a tip, maybe to diagnose clinically?
The clinical, that is very difficult, because if there is one clear clue, there will be no patient's journey and there will be no delay in the diagnosis. So I dare to say, yes, they may look differently, but you need a lot of clinical experience, and this is subjective, this type of assessment, so we do not have a measurable clue. But the color is a little bit more different, so the scaling is usually very fine. So if it is a psoriasis, the scaling will be much more. If it is a pityriasis rubropilaris, probably the scaling will be less, or you will have to nap clear. And then this combination in a very, very pronounced disease, classical erythroderma and palmoplantar keratoderma and ectropium, this is very typical for the Sézary syndrome. However, once you have it, the blood disease is also not a problem at all to detect. So what we aim for is to diagnose those patients before the skin disease is so visible. This is the big challenge.
I imagine it's quite difficult. There's another question concerning advanced disease. So there's a member asking, what would be the optimal combination chemotherapeutic regimen if it has to be considered as a treatment option?
Yeah. We do not believe that chemotherapy at all is an optimal treatment for advanced disease. So we are dealing here with a tumor that is part of the immune system, and as such, patients are per se immunosuppressed because of the disease. So chemotherapy is really a option for it's a second choice, let's say, when we have already when the disease is not responding to the other treatments. Otherwise, if we go to chemotherapy, we definitely recommend monotherapy at the beginning with liposomal doxorubicin delivering the best data at the moment, or gemcitabine. Polychemotherapy is a little bit more difficult, so this should be, if at all, within the setting of a quick transplant planned afterwards.
Great. And there are some more. They are all taking advantage of your clinical expertise. So, and it's good. They do. It's the moment to do it. So there's a question asking, Professor, do you consider early combination of acitretin with skin-directed therapy in treating early-stage CTCL?
Yeah, this is one preferred option. So as said, monotherapy is the first recommended option also for skin-directed therapies. But as soon as you use acitretin or any retinoids, those are second-line systemic therapy for early skin disease. Of course, it is excellent and classical idea to combine them either with PUVA therapy, it has even a name, the RePUVA, also well established in lymphoma, or with other skin-directed therapies. And the advantage, acitretin is not exactly the same as Bexarotene, which is approved for the indication of cutaneous lymphoma, but in the absence of Bexarotene is definitely a very good option, or in case where side effects of Bexarotene make it intolerable for the patient, but you still need a retinoid.
Thank you. And there is another one, again, for a specific patient now. They ask, what would be your recommendation of treatment for a young patient, male, with mycosis fungoides located on genital area, non-responding to methotrexate?
So it depends. This is interesting because treating patients online is always a very difficult task, but I can see the first thought that comes to my mind. And then, of course, you have to consider the big clinical context around your patient. So if it is a unilocular mycosis fungoides, or if it is one very persistent long-term lesion in the genital area, and without further extent of the disease and without big dynamic, I would favor palliative radiotherapy to reduce the disease burden in this area with an excellent clinical outcome usually. But you have to bear in mind that this type of therapy is not in the context of cutaneous T-cell lymphoma, is not curative, but is palliative. So you have to follow up the patient and you have to know that on the same location, you can repeat it a few times until reaching a certain number of grays, let's say 50 grays, and then it is over. Another issue is if it is, it depends because you do not say if it is a tumoral lesion or a patch lesion. In both cases, I would recommend to check for expression of CD30. So depending on the stage of the disease, if it is 1A, then probably you would go for chlormethine gel as well. You can try that one. Also in the genital area, it is possible. Or if it is a tumoral lesion, so the patient is stage 2B disease and above, you should consider also Brentixumab after the failure of methotrexate.
Okay, that's a tough case, I imagine, for the person addressing it. There's another one again on therapeutic approach. It's concerning folliculotropic mycosis fungoides. Which is the therapeutic approach that you would recommend?
Basically, the recommendations for folliculotropic mycosis fungoides are the same as for mycosis fungoides in general. There is a tendency, however, that folliculotropic mycosis fungoides responds a little bit better to retinoids. So I will definitely not miss this option in the therapeutic ladder. Acitretin or the approved Bexarotene should be an option for these patients, and then all other options depending on disease extent.
Thank you. And I think the person that asked about the genital area gave some clarification. She said 3, and it's non-CD30, and it's tumoral stage.
It's tumoral stage.
Genital. Yes.
Yeah, this is more difficult. So it's stage 3 disease, but this is erythroderma. It's not possible. Or maybe it's this.
No, he has 3 lesions, and it's tumors.
Tumor lesions.
On CD30 in the genital area. So it's the recommendation of the young patient male with the mucosis fungoid in the genitals. Because there are a lot of questions.
Well, it should be probably interdisciplinary discussed also in the local setting with all involved colleagues. But radiotherapy should be most probably considered as a first option, or chlormethine gel. If it is not responding to methotrexate. What else do we have? Or a combinational treatment.
It's a tough case. There's another case that another person that asked that do we always need a very high expression of CD30 to start Brentuximab treatment in mucosis fungoides?
This is very interesting question, and there is indeed also some data in the literature. So at the beginning, when the clinical trials were running to explore the action of Brentuximab in general, first it was postulated that you need the expression of CD30 above, at the beginning probably we started above 30, then 25, now it is above 10. And the truth is that to my personal experience, it is more the type of the lesion that counts. So if you have large cell transformation, you should definitely consider this therapy. There are also data, especially from the United States group, that clearly show that the response to treatment does not correlate with the level of expression of CD30. Of course, it is more difficult if the patients are completely CD30 negative. There are also cases that are completely CD30 negative that still respond to treatment, but this is more of an exception at the moment, so more data are needed. But if it is very high or not so high CD30 expression, as soon as you see large cell transformation and clusters of CD30 clearly membrane positive cells, then you should consider this as an option. One idea is that probably our detection limit of the immunocytochemistry for CD30 is not high enough to assess all the CD30 positive cells, but this is still in research.
So the questions are coming in. So it's amazing how many people have questions and want to take advantage of having the expert in the room. So
thanks so much.
One person asking, inhibitors of calcineurin are indicated instead of corticosteroids?
This is also a very tricky question we have, but yeah, the answer is yes, you can do it. However, there are not so many data because, unfortunately, the history of the development of calcineurin inhibitors, probably some 20 years ago, was linked to the anecdotal case report or casuistics of a few patients that were reported to have developed some malignant lesions after application of calcineurin inhibitors. However, those data have never been confirmed in large-scale trials. On the contrary, it is now known that calcineurin inhibitors actually do not induce lymphoma, but it makes it difficult when you have this historical background in medicine. It is always difficult to completely switch gears and say, yes, you can use them. There have been also a few studies that are probably not yet published or not finished that are analyzing the effect of calcineurin inhibitors in cutaneous lymphoma, and you can definitely consider it also as an option when you want to spare corticosteroids, also in the facial area. Of course, the responsibility in this case lies particularly on the physician, and then the patient have the patient information brochure that most probably will always report those historical events. So you have to bear in mind that you have to openly discuss this with your patients.
And since we are in the corticosteroids kind of department, there is one again addressing a question now on corticosteroids and systemic corticotherapy in an advanced stage. Does it have any good effect?
Well, it has a temporary good effect, as steroids always have on tumor disease, but it's not something that you would recommend. if you really need, there's no indication for systemic steroids, but it is done. So with a rather high dose for a short term, yeah, you can achieve some kind of a temporary positive effect, but then still you will dampen the immune system, as just as in every tumor. This is an option that we have, and if there is an indication to improve quality of life, temporary effect, or while waiting or bridging to some other option, yeah, you can consider it, but actually it's you're not treating the lymphoma with this therapy. Mm-hmm.
It's kind of putting the fire a bit down, but not extinguishing it. So you have I think this would be our final question, because we are running almost to the end, and it's quite an interesting one. It's long, but it's very relevant, I think. I'm quite interested to hear your answer. So we learned that we might need a high number of biopsies until we as dermatologists or our pathologist colleagues are able to diagnose mycosis fungoides. Is this also true today, or flow cytometry spreads the diagnostic process? I have no experience with flow cytometry. Thank you. Excellent presentation.
Thank you very much for the positive feedback. I have to clarify, however, that those are two completely different diagnostic pillars. So histology and flow cytometry, they're complementary. They're not mutually exclusive. So histology is for skin disease. Histology is for predominantly mycosis fungoides or other types of lymphoma. We need a lot of biopsies because of the uncertainty of the diagnosis. This is completely true, especially in very early stage of the disease. It is very difficult. Pathologists actually cannot make the diagnosis. This is also something different from the regular tumoral diagnostic. For skin lymphoma, every pathologist, hematopathologist, dermatopathologist is well aware of the fact that we need a clinical pathological correlation. So we need clinicians and pathologists working together to fulfill the criteria for mycosis fungoides. Sézary syndrome, skin biopsy in Sézary syndrome is actually not diagnostic and is not part of the diagnostic criteria. This is a very important question because it's non-specific in more than, depending on literature data, 40 or 50%. So in half of the cases, we don't even have a chance to make the diagnosis. Flow cytometry, we need for blood disease at the moment, what is currently established in the guidelines. And blood disease, this is for Sézary syndrome and for advanced mycosis fungoides. But still, we cannot make the diagnosis mycosis fungoides solely on blood disease. This can be done only for Sézary syndrome. Maybe in the future, what can really help the diagnosis would be flow cytometry on the skin, but this is still very experimental. It's done in some laboratories. It is helpful, but we are not yet there to establish it on a high throughput platform for every patient.
Okay, I think my slide has a bit technical difficulties. So I'll ask one final question. I said that this was the last one, but the people keep sending questions. So it's, how do you treat extranal purely cutaneous T NK cell lymphoma? Thank you.
This we did not touch upon non-MF and non-SS cutaneous lymphoma a lot today. Cutaneous NK cell lymphoma is one of the entities with bad prognosis, and in general it takes some time to diagnose it because it's a very rare entity. So usually until the diagnosis is done, the disease is also quite advanced. It has also a very quick progression, and the prognosis is really bad. So the option here is stem cell transplantation, allogenous, as quickly as possible. And there are no other established options. Once again, check for CD30 expression because this can gain some time in the therapeutic ladder. If you have CD30 expression, you can try Brentixumab or otherwise chemotherapy and transplantation. of course, for locally advanced lesions, palliative radiation therapy is also an option. Mm-hmm.
Thank you. You were very thorough, and I think everybody enjoyed a lot this session. We arrived at the end of another successful, I think, webinar. And please remember that in 2 weeks we have another one. So please join us. Emmanuela, I don't know if you want to say something to our audience before hanging up, as let's say.
Well, thank you very much. I really enjoyed being with you and talking on cutaneous lymphoma. This is one of my favorite subjects. If you enjoy further talking to me, you can put the last slide with my email. I'm happy to take questions if the audience may have some, even after the time of the webinar. May not.
That's very generous.
Usually, I respond at one time.
That is very generous. Thank you. And maybe I should take the opportunity here to say that this year we plan to have a masterclass on skin cancer, and that our speaker here, Professor Guenova, and also our previous speaker, Professor Samimi, will join us in this masterclass. So this was just a little taste of the masterclass to come this year. And from the Education Committee. And without further ado, I will pass you on to our specialist here in webinars and webcasts, Mr. Christopher Horsham. Bye.
Thank you very much. We would like to give a special thank you to our presenter, Professor Emmanuela Guenova, for presenting and sharing her expertise with us. We have received a lot of positive feedback for your presentation. And thank you to Professor Mirto Tracatelli, the chair of the EADV Education Committee, for moderating the questions. And on behalf of the EADV, thank you for joining us today and sharing your great questions with us. If you would like to expand your knowledge on cutaneous lymphoma, EADV members have access to a highly rated intermediate level online course on the EADV Learning Platform. And join us every other Wednesday for EADV Live, webcasts of dermatology and venereology, brought to you by the EADV. Our next webcast will be on March 10th, entitled Everything You Ever Wanted to Know About BXT and Fillers, but Were Afraid to Ask. Thank you and have a wonderful day.